This timeline tracks an infant's first year. Pureed foods start at 6 months, cow's milk at 12. Newborns feed every 2 to 3 hours, 8 to 12 daily sessions, 10 to 20 minutes per breast. For the first 6 months, guidelines dictate exclusive breastfeeding. For mandatory supplementation, exclusively breastfed infants must receive vitamin D shortly after birth to prevent bone demineralization. Premature infants exhaust iron stores early, requiring iron before 6 months. Additionally, infants of strict vegan mothers must receive vitamin B12. By 4 to 6 months, healthy infants undergo a physiological shift, gaining metabolic reserves to sleep through the night. Continuing overnight feeds past this developmental milestone trains the infant's circadian rhythm to wake specifically for feeding. To break this cycle, nocturnal feedings must be discontinued. You must establish this strict chronological baseline. Recognizing pathological failure to thrive on a clinical exam relies entirely on identifying exactly where a patient deviates from these normal milestones. Beyond establishing a feeding schedule, breastfeeding initiates systemic physiological changes in both the infant and the mother. Breast milk transfers maternal immunoglobulins, reducing acute otitis media, preventing severe gastroenteritis and respiratory tract infections. For the mother, lactation triggers oxytocin release, driving rapid uterine involution and decreasing postpartum bleeding. Long-term, it correlates with a significant reduction in breast and ovarian cancers, alongside improved maternal-infant bonding. This matrix contrasts systemic benefits with absolute contraindications. Breastfeeding must be withheld for active, untreated tuberculosis, herpetic breast lesions, or active varicella infection, occurring within 5 days prior to or 2 days after delivery. Exposure-based absolute contraindications include maternal chemotherapy, ongoing radiation therapy, and active abuse of street drugs or alcohol. Maternal HIV infection requires a geographic distinction. It is an absolute contraindication in developed countries where safe formula and clean water are available, but may be permitted in resource-limited settings where malnutrition poses a higher immediate mortality risk. Medication-assisted treatment for opioid use is an exception. In a supervised program adhering to prescribed methadone with active recreational drug use, breastfeeding is encouraged. Lactation is a heavily protected physiologic process. The threshold to mandate cessation is high, requiring specific testable infectious exposures or dangerous pharmacological variables. This graph charts normal neonatal weight trends. Due to the excretion of excess fluid acquired in utero and a natural delay in maternal lactogenesis, healthy infants consistently lose weight over the first 5 days of life, returning to their birth weight by day 14. The maximum permissible weight loss within this initial 5-day window is 7% of the infant's total birth weight. You can confirm adequate hydration during this period by tracking output. For the first week of life, the number of wet diapers per day should exactly equal the infant's age in days. If an infant loses less than 7% of their weight and meets the wet diaper metric, no active intervention is required. You provide reassurance, continue exclusive breastfeeding, and schedule a routine follow-up. The clinical picture changes drastically if the infant loses 10% or more of their birth weight. This crosses into pathological territory. At the 10% threshold, you must actively intervene. The protocol requires assessing latch mechanics, measuring the infant's weight daily, considering formula supplementation, and evaluating serum electrolytes and glucose to check for systemic dehydration. Clinical decision-making hinges entirely on these precise percentages. A sudden drop from 7% to 10% turns a routine observation into an active medical intervention. This diagram maps the physical exam findings of dehydration. Beyond isolated weight loss, you will observe a sunken fontanelle, dry mucous membranes, decreased skin turgor, and delayed capillary refill. If the infant exhibits these signs but remains stable and can tolerate enteral feeding, the correct intervention is mild to moderate oral rehydration. However, if fluid loss progresses to lethargy, tachycardia, and severe hypovolemic shock, oral intake is no longer sufficient. Severe dehydration mandates an immediate intravenous fluid bolus. You must administer 20 milliliters per kilogram of an isotonic solution using either normal saline or lactated ringers. This diagram illustrates the 5 mechanistic pathways of chronic failure to thrive. When acute weight loss becomes a chronic pattern, the pathology always stems from inadequate intake, malabsorption, increased metabolic demand, severe reflux, or immunodeficiency. Inadequate intake usually points to psychosocial factors, improper formula mixing, or poor latch. In contrast, malabsorption indicates a functional gut defect, such as celiac disease disrupting the mucosal lining, or cystic fibrosis causing pancreatic insufficiency. Increased metabolic demand occurs when chronic systemic stressors, like an undiagnosed congenital heart defect or chronic infection, burn through standard caloric intake, leaving a deficit for actual growth. Acute dehydration and chronic failure to thrive are the two primary avenues of systemic collapse. Both occur precisely when the established physiological baselines of fluid and caloric intake are broken. When dietary intake is strictly limited, specific nutritional deficits emerge. An infant exclusively breastfed by a strict vegan mother will rapidly deplete their trace reserves, presenting with deficiencies in vitamin B12, vitamin D, and calcium. Deficiencies in water-soluble vitamins present with highly specific clinical profiles. A lack of thiamine, or vitamin B1, manifests as beriberi, involving neuropathy and heart failure, or Wernicke-Korsakoff syndrome, marked by ataxia and confusion. In a clinical setting, if a patient presents with severe malnutrition or alcohol use disorder, thiamine must always be administered before intravenous glucose to prevent triggering acute, irreversible encephalopathy. Niacin, or vitamin B3 deficiency, presents as pellagra. You can identify it clinically by a specific triad of symptoms: severe diarrhea, asymmetric scaling dermatitis, and progressive dementia. This flowchart separates two distinct causes of megaloblastic anemia. A deficiency in either folate, vitamin B9, or cobalamin, vitamin B12, will result in identical macrocytic red blood cells on a smear. The critical differentiator is neurological. Vitamin B12 deficiency causes subacute combined degeneration of the spinal cord, leading to severe neurologic deficits. Folate deficiency causes isolated anemia with an entirely normal neurological exam. Vitamin C deficiency impairs collagen synthesis. The physical exam will reveal connective tissue breakdown, characterized by gingival bleeding, corkscrew hairs, and perifollicular hemorrhage. Diagnosing water-soluble deficiencies requires precision. You must map specific dermatologic and neurologic exam findings directly to their underlying biochemical failures. Fat-soluble vitamin deficiencies present differently. Without adequate vitamin D, calcium and phosphorus cannot be absorbed from the gut, leading to osteomalacia, severe bone pain, and pediatric rickets. Vitamin K deficiency directly impairs coagulation factors 2, 7, 9, and 10. In a newborn, this presents as uncontrolled bleeding from the umbilical stump, or in older patients, sudden hemorrhage following surgery. This matrix differentiates the laboratory profiles of these bleeding pathologies. While both conditions show normal platelet counts, vitamin C deficiency presents with normal coagulation studies and mucosal bleeding. Vitamin K deficiency presents with elevated PT and PTT alongside deep tissue bruising. Trace mineral deficiencies produce highly visible physical signs. Zinc deficiency is uniquely characterized by sudden alopecia, an erythematous perioral rash, and an altered sense of taste. Copper deficiency presents with microcytic anemia paired with severe neurologic dysfunction, mimicking B12 deficiency. Selenium deficiency uniquely triggers isolated cardiomyopathy and cardiac failure. The clinical strategy for testing relies on reverse engineering these end-stage presentations. Identifying a specific symptom, like an isolated cardiomyopathy, immediately points to selenium. Identifying a perioral rash locks the diagnosis onto zinc, eliminating all other nutritional variables. Mastering pediatric nutrition requires tracing severe, end-stage systemic pathologies directly back to the exact chronological milestone, maternal contraindication, or specific dietary threshold that was missed.